All right, welcome to The Explainer. Today, we're jumping right in to build a practical guide for one of the most important roles you play, counseling patients through pregnancy and the postpartum period. Think of this as your go-to toolkit for the front lines.
You know the situation. We've all been there. A patient walks up to your counter full of questions, maybe a little anxious, looking for your advice. The stakes feel incredibly high, right? So how do you handle that? How do you walk them through it with real confidence? And that's the thing you've got to remember. For so many of your patients, you are the expert they can see today, the one they trust the most. Your guidance is absolutely vital. So let's dive into the principles that can make these conversations not just easier, but better. Okay, first things first, we have to establish the foundation. These are the core principles and the big myths we need to bust that should really guide every single one of these patient interactions. Think of this as your mental checklist every single time. First up, always start with non-drug options. Then you gotta know, where are they at in the pregnancy, or how old is the infant? That timing changes everything. And remember, it's never about zero risk. It's always about weighing the risk of treatment against the risk of an untreated condition. From there, it's simple. Stick to drugs with solid safety data, use the lowest dose that works for the shortest time possible, and hey, always try to use single ingredient products. Why add extra stuff if you don't have to? Okay, this next number, this is one of the most powerful tools you have. 1 to 3%. That's the baseline risk of a major fetal malformation in any pregnancy, with or without any medication at all. Just sharing this one piece of context can be a huge relief for an anxious parent-to-be. It helps them understand the goal is about managing risk, not this impossible chase for zero risk.
All right, let's bust myth number one. This idea that a pregnant patient should just stop taking everything. Nope. The real conversation we need to have is about reframing that risk. An uncontrolled condition, like, say, asthma or depression, can often pose a much greater risk to the pregnancy than the actual medication used to treat it.
And that leads us to the next big one, the natural means safe myth. Not so fast, especially not in pregnancy. The truth is, we just don't have good, reliable human data for most herbal products. And some, like blue cohosh, we know for a fact they're harmful and should be avoided, period. The same risk-benefit thinking applies here too. Okay, so we've got our principles down pat. Now let's get practical and move to the front lines. Let's talk about how to manage some of the most common things you're going to get asked about every day in your practice. 70%. That is a huge number, right? Well, that's roughly how many pregnant people experience nausea and vomiting of pregnancy, or NVP. It's incredibly common, and we all know morning sickness is a terrible name because it can be an all-day, all-night thing. Your advice here can literally change someone's entire trimester. So here's your playbook. You start with the non-drug stuff. Smaller meals, avoiding trigger smells, maybe even acupressure bands. And here's a super important pro tip. If the nausea is so bad they stop their prenatal vitamin, you have to remind them to keep taking a separate folic acid supplement. For first-line meds, it's all about pyridoxine. That's vitamin B6, often combined with doxylamine. That combo is the gold standard. If that's not cutting it, then you can move on to second-line options like dimenhydrinate or a standardized ginger supplement. For allergic rhinitis, the game plan is pretty similar. Non-drug options like a simple saline nasal spray are a fantastic first step. If they need meds, first-generation antihistamines like chlorpheniramine are a great choice because we just have so much safety data on them. Second-gen options like loratadine and cetirizine are also considered safe. You'd only really think about intranasal corticosteroids like budesonide if the antihistamines just aren't getting the job done.
All right, let's shift gears a bit. Moving beyond specific ailments, let's cover 3 absolute essentials that will come up in almost every pregnancy consultation: supplements, substance use, and, of course, vaccinations.
These are the non-negotiables. Folic acid is absolutely critical, ideally starting before they even conceive. Iron, they're going to need it, but give them a heads up that it can make that first trimester nausea and constipation a little worse. Calcium is so important for the baby's skeleton and mom's bone health. And here is a key warning. Tell them not to double up on multivitamins, because high doses of vitamin A can cause birth defects. Now, when it comes to substances, your advice needs to be crystal clear. No gray areas. For alcohol, cannabis, and smoking, the recommendation is complete avoidance. We don't know of any safe amount, so the advice has to be 0. For caffeine, there is a little wiggle room. The guidance is to limit intake to 300 milligrams a day or less. This is so simple, but so important. There are 2 vaccines recommended in every single pregnancy. The inactivated flu shot can be given at any time. And then there's the Tdap vaccine for tetanus, diphtheria, and pertussis. This one should be given between 27 and 32 weeks. And this is the amazing part. It actually passes antibodies to the baby, protecting them from whooping cough in those first vulnerable months of life.
And our duty of care doesn't stop at delivery. That postpartum period, the 4th trimester, is such a critical time for both the patient and the baby, and it comes with its own unique set of counseling needs.
So when you're counseling on medications during breastfeeding, a few simple rules of thumb can make all the difference. First, timing is everything. Have them take the dose right after a feed to minimize the baby's exposure. Shorter half-lives are your friend, and if you have a choice, pick the drug that passes the least into breast milk. Oh, and for pain, acetaminophen is the hands-down analgesic of choice.
Postpartum contraception comes up a lot, and this timeline really helps clarify things. Around 3 weeks postpartum, progestin-only methods are on the table. You want to wait until about 4 to 6 weeks for things like IUDs and to make sure breastfeeding is well established. And critically, combined contraceptives, the ones with estrogen, are delayed until after 6 weeks. That's to minimize the elevated risk of blood clots in the postpartum period.
So let's bring all of this together. The goal here, the whole point of this explainer, is to empower you to have these crucial conversations with confidence and with precision.
And this quote right here really gets to the heart of it all. It's not just what you say, but how you say it. Your calm, non-alarming, and empathetic delivery of accurate information, that's what transforms a simple transaction into true patient care. So I'll leave you with this question to think about. Whether it's that 1 to 3% baseline risk number, the tiered approach to NVP, or the timing of the Tdap vaccine, what is the one piece of information you'll use to make your very next patient consultation even better? Thanks for watching The Explainer.